My name is Liz Salme. I'm the Senior Strategist of Research Dissemination for OpenNotes. I'll be introducing you to the cast of characters along the way. Before we keep going, I want to go over some housekeeping items with you. All attendees, you folks, are muted throughout today's presentation. Please put your questions in the questions box in the section of this platform, and we'll address your questions at the end of the presentation. However, answers to some of your questions may be provided throughout the presentations. These responses are posted by Deb Wachenheim, who's the Assistant Director of Research Dissemination for OpenNotes. Deb knows her stuff. This webinar is recorded and will be available for later viewing on our website and on the YouTube channel, OpenNotes YouTube channel. You'll also receive an email in about a week with links to this recording, and you can share it with all of your colleagues and anybody who needs to know. So everyone who just joined in the last 2 minutes, I want to say welcome again to the OpenNotes and Pediatrics and with Adolescents webinar. I'm super excited for today's session. I'm really glad you're with us. You're going to hear from experts around the country in OpenNotes. Think of this hour as a crash course in the practical aspects of OpenNotes and Pediatrics, and we're presenting in 4 segments. So one, you're going to hear from Dr. Kate DeRoche, who's the Executive Director of OpenNotes. Then you'll hear from our 2 special guest presenters, Dr. Bourgeois, Dr. Kuelbs. Then we're mixing things up a bit with a mini panel where Dr. Kuelbs is going to ask Dr. Bourgeois some really specific detailed questions that are tricky around OpenNotes with pediatrics and then adolescents. And then finally, we'll transition to a Q&A to really dig into the top questions you have. So first, I'm going to introduce you to Dr. Kate DeRoche. Dr. DeRoche is the Executive Director of OpenNotes and an Associate Professor of Medicine at the Harvard Medical School. She is a distinguished health researcher with expertise in emerging trends in healthcare delivery. Dr. DeRoche.
Thank you, Liz. Thanks to everyone for joining us today, particularly those of you who are in the South or Southwest or other parts of the country that are really terribly affected by this last winter storm. We really appreciate you coming to spend some time with us. So I am going to be very quick and we'll get right on to the main event. My job is to just give you a very fast overview of what is OpenNotes and to make sure that we're all kind of on the same page. So OpenNotes, capital O, capital N, is a group of, we're an initiative, we're based at the Beth Israel Deaconess Medical Center, and we have collaborators around the country, and we focus on improving transparency in healthcare and evaluating what happens when patients have easy access to their health information. OpenNotes, 2 words, is just when patients can easily read their visit notes. So it's not a software, we are not a platform or a vendor of any kind. We are simply focused on the idea of transparency, and we're funded, completely funded by philanthropy. You can see on this slide some of our major philanthropic donors, and we also have some private donations from individuals, but we are primarily funded by private philanthropies and some federal government grants. Next slide. So OpenNotes, which started as a pilot project in 3 healthcare organizations, one, my own Beth Israel Deaconess Medical Center, Harborview Hospital, which is located in Seattle, a safety net hospital, and Geisinger Health System, serving a primarily rural population in Pennsylvania. That's where OpenNotes started. With these 3 organizations, there were about 100 primary care clinicians and about 20,000 patients. And the results from that pilot study showed that when patients have easy access to their notes, when they're reading their notes, they report benefits around engagement, around understanding their care plan, around how they understand and take their medications. It increases trust in they feel increased trust in their providers. There are very few that say, I was offended or upset by something that I read. So based on those findings and supported generously through philanthropy, we have managed to spread the idea and spread the practice of sharing OpenNotes to now more than 260 organizations and 54 million people who are signed up on a portal, patient portal somewhere in the United States with access to their OpenNotes. I think there's a small lag between what I'm seeing and what what's happening with the slide advancement. So what is coming next is a really big change, which is undoubtedly why many of you are on this webinar with us today. So on April 5th, 2021, the new federal information blocking rule goes into effect. So this is a result of the 21st Century Cures Act, which had a provision in it that essentially directed HHS, the Department of Health and Human Services, to improve interoperability and to give patients electronic access to all of the information contained in their electronic health record. That was in 2014. Fast forward to 2020, and a lot of discussion about what all means. And we have the situation where we're in today, where now 8 different kinds of notes will have to be shared with patients, made available either through the portal or through a third-party app on request from patients without extra charge or delay. So that is an enormous change in how people are, how patients, in the types and amount of information patients are going to have access to on the patient portal. There are some exceptions to this sharing, and I imagine some of the questions that we'll get today will be focused on these exceptions. So the one that I will talk about just briefly is the federal preventing harm exception. So this allows a provider to hide a note or to keep a note back from the portal if the provider has good reason to think that releasing this information is going to cause harm. Either there's a substantial risk to harm either to the patient or to another person. Now, this can't or should not be interpreted as broad access to block all notes for a particular patient, or a provider just saying, well, I think all my notes could cause harm, so I'm not going to release any of them. It should be no broader than necessary, and it should be on a note-by-note specific basis. So that's it for me for today. A broad and quick overview. I'm going to turn it back over to Liz so she can introduce our panelists.
Thank you, Kate. And we have other webinars. We went deep into 11 years of research around OpenNotes in a variety of ways, but today we're focusing on adolescents and in pediatrics and adolescents and OpenNotes. And I'm really excited about today's presenters. And first up is Dr. Fabienne Bourgeois. Dr. Bourgeois is a pediatric hospitalist and Associate Chief Medical Information Officer at Boston Children's Hospital. I think it's the first site where you're doing OpenNotes ever in the country. I think you guys get the credit there. Dr. Fabienne Bourgeois is the physician lead for patient-facing applications and has been involved with the development and implementation of the patient portal for the last 15 years and leads the OpenNotes initiative at Boston Children's. Her specific interests are related to privacy and confidentiality in the digital space, as well as leveraging informatics to partner with patients and families to improve the quality of care. Dr. Bourgeois, it's yours.
Thank you so much, Liz. That was wonderful. All right, so I'm going to talk to you a little bit about our journey here at Boston Children's with OpenNotes. I'll start, though, with just mentioning that in addition to all the benefits we've heard among the adult populations in terms of leveraging OpenNotes for our patients and families, there are specific unique benefits for the pediatric and adolescent population. In addition to assisting patient and family and empowering them with having access to all of their information, it's very helpful in terms of sharing information among multiple caregivers. Frequently, there's only one parent who can come to a visit, whether it's outpatient or during an inpatient encounter, and having the notes as a resource to share among the caregivers is particularly powerful. It also, more so than any other population, is going to provide a longitudinal medical narrative for the patient journey. So patients who are born now will essentially have access to all of their notes and all of their information starting from birth onwards. It also particularly helps for our patients with special healthcare needs. Many of our patients with special healthcare needs are often seen at multiple sites of care, which results in a lot of fragmentation of health information. and allowing the patients and families to be the stewards of all of their information and be able to collect information across all of their sites to make sure they can share this information appropriately is particularly helpful. It also facilitates the transitions of care for adolescents who are transitioning to adulthood. The adolescents can start getting access to their information, and it helps as a tool to inform them and help them understand more about their health conditions, about their treatment plans, so that once they have to take ownership of all of their health care, they are ready to do so. And next slide, please. There are, of course, specific challenges in the pediatric and adolescent populations that we are all dealing with. The first one is around adolescent confidentiality. As we all know, there are specific state statutes that protect certain information where patients can come and seek care without information being shared with their parents. This is generally around matters of reproductive health, sexually transmitted illnesses, substance abuse, and mental health. There is huge variation across states in terms of what the laws specifically say about how this information is handled. And even there's institutional variation in terms of how the state laws are interpreted. Either way, though, there is an expectation by the patient that the information not be shared with a parent. The second major challenge is around information that may be provided by a parent or a legal guardian with the expectation that it not be shared with someone else. So it may be information that an adolescent shares with the expectation it not be shared with a parent, or information that a parent shares with the expectation that it not be shared with the adolescent or with the other parent. This tends to be information around adoption, misattributed paternity, parental substance abuse, domestic violence, maternal prenatal tests. There's quite a long list of information that we end up, that our patients or parents ask us not to share with others. And then there's lastly also the conundrum that providers come across when there are significant disagreements between the patient and parent and the provider around diagnoses or treatment plans. And trying to make sure that we retain a therapeutic relationship and do not end up causing a problem with a provider relationship around our documentation. This is particularly challenging around areas where there is suspicion of medical child abuse that has not yet been confirmed. Next slide, please. So I'll tell you a little bit about the My Children's Patient Portal. Our patient portal has a little over 140,000 users at this point. We have over 35,000 unique user logins per month. Many of those are around accessing notes prior or after a visit. We have a hybrid solution of both Cerner and Epic portals. And we first launched as a custom portal back in 2007. Next slide, please. I'll start off by talking a little bit about our access policies, because who has access to the notes will inform how the notes are handled and how you implement OpenNotes. At our institution, for patients who are under the age of 13, our parents and guardians have access to all information except select confidential information. Again, this may be information that is shared by the parent with the expectation that it not be shared later on with the adolescent or with the other parent. Next. For our 13 to 17-year-olds, the 13-year-olds can now have access to the portal as well, and we continue to curate confidential information. Parents retain access to non-confidential information, so they can continue to have access to non-confidential notes, as do our adolescents. And next, please. And then lastly, once a patient turns 18, we completely disconnect the parent. We do not allow any proxy access for our 18-plus-year-olds unless the parent has been a court-appointed guardian. We also notably do not allow access to historical confidential information once the patient turns 18. Next slide, please. So we first went live with OpenNotes in 2014. We leveraged an ambulatory-wide project in which we were improving our documentation. and we introduced confidential note types for all of our ambulatory clinic. The non-confidential notes were then automatically released to the patient portal. We did have individual meetings with some of our higher risk clinics that tended to manage a lot of sensitive information. This included our psychiatry clinics, adolescent, gynecology, our child protection team, and our adolescent substance abuse program. These clinics asked for an initial deferral with the option to join later. And we did have a technical limitation at that time, which required that the appropriate note type be selected at the time of note creation. And there was a lot of concern that rotating trainees would not choose the correct note type in these clinics, which would lead to an inadvertent disclosure. So these clinics were excluded from our initial ambulatory-wide release in 2014, as were inpatient and ED notes at that time. Next slide, please. In collaboration with Dr. Cynthia L and the rest of the OpenNotes team, we then sent out a survey in 2016 where we surveyed patients both at Boston Children's and at Beth Israel Deaconess Medical Center to get feedback in terms of how they were using their notes and how it helped them in the care of their child. So I'll direct your attention to the red box, which essentially is the data from Boston Children's, where we asked our parents around how they used their notes and how it helped them. The most notable data that we got from here and what most parents were telling us was that between 75% and 80% of our parents mentioned that it would help them understand reasons for tests, understand the actual interpretation of a test result, and it could help them understand the reason for a particular referral. So a lot of what the notes really helped them with was really providing context to some of the other data that was in the chart. Next slide, please. We then also built on another study that Dr. Cynthia L had done around getting feedback, direct feedback on specific notes from our patients and families. She had initially done this study with the OpenNotes group in two primary care sites at Beth Israel Deaconess Medical Center, and we expanded this to both Boston Children's as well as a network of hospitals in South Carolina and Georgia. And essentially what we asked was that patients and families provide feedback on how well they felt that a note described their visit, how well did they understand the care plan as it was described by their provider in the note, whether or not there were any inaccuracies in the note. And we also asked specifically about bothersome language in terms of how providers documented in the note. And we also asked for a voluntary positive feedback from our providers. Next slide, please. So the center column is the data that is specific to Boston Children's, though essentially we had very similar results across the three sites. Most of our patients and families noted that they understood what the note contained. They understood the care plan and expected to follow the care plan as it was denoted within the note. But about 35% of our patients and families actually reported back that there was some sort of inaccuracy within the note. A fraction of them, about 8%, also noted some bothersome words, which I'll tell you about in a second as well. And many of them also volunteered positive feedback, in particular in some of the reports where they had noted inaccuracies. Next slide, please. The specific areas where we saw most of the inaccuracies, or most of the inaccuracies were reported by our patients and families, were around the HPI. So what symptoms, why they came to the office visit, and the full description of the symptoms that their child had had since their prior visit. Not surprisingly to us, the problem list and medication list tended to have quite a few inaccuracies. And often they also noted that there was just something else that was very important that was missing from the note. There was also a large category of other issues that we had not previously categorized, which included errors in sightedness, so right-left-sided errors. It included errors in terms of the name of the child, and also in a couple of instances, also the wrong note in the wrong child's record. Next slide, please. In terms of the bothersome language that our patients and families reported, though there were very, very few who actually reported bothersome language, the types of language that they reported as being bothersome included language related to stigmatized diagnoses. This included obesity, developmental delays, or malnutrition. Language that was perceived as being critical, in particular critical of the care being provided by a parent for the child. Misrepresentations of communications they had noted that they had had with other clinicians, and language that was perceived as signaling distrust of the information that was being provided, either by the parent or by the patient themselves. Next slide, please. Ultimately, this was part of a QI project, and we ended up feeding back the information to our providers. And if you look at the second column here, about 70% of the inaccuracies that were reported by our patients and families resulted in an update to the note with a correction of the inaccuracies as was reported by our patients and families. 54% of the actual inaccuracies or concerns that were noted in the documentation were actually also felt to be an actual or possible safety concern by our quality improvement team. Next slide, please. There was also a lot of positive feedback that we got from our patients and families that noted just how much they appreciated having access to these notes. One parent said, "I love this feature of being able to view the note. It perfectly summarized the visit and was nice to be able to reference and share with my husband, who wasn't able to make the appointment. I appreciate Dr. So-and-so taking the time to write such a detailed note." This goes back to Dr. Chaithan Sarabu's viewpoint about what the unique benefits are in pediatrics, where essentially, again, it's not all caregivers are able to be there, and having the note as a resource to share with others is very powerful. Another parent noted, "I greatly appreciate the level of detail and thought put into these notes. I realize this takes a lot of time, and I'm grateful for that time. The notes accurately reflect my concerns and show you really listened, as well as provided concrete steps for a path forward and reassurance." This is another aspect that we hear often from our patients and families, where the note really serves as a feedback loop, where the patient is reassured that they communicated their concerns appropriately and that there's a shared mental model in terms of what is going on and what the plans are moving forward. And lastly, we are so grateful to have the notes to review. It is overwhelming as a parent to absorb all of the information at the time of the visit, so the notes are very helpful to review. We hear this often from our parents about how stressful some of these visits can be, and that they often only remember a fraction of the information that was discussed. So the note allows for an additional review of all of that information. Next slide, please. We also ended up doing a study looking at why we were using confidential notes here at Boston Children's. So why were our providers choosing OpenNotes or confidential notes? Dr. Chase Parsons did this study looking at a 1-year period from 2016 to 2017 for patients under the age of 18. We looked at about 12% of the confidential notes that had been created during that period of time. And we found that about 84% of those notes either contained confidential information or contained confidential screening questions. So questions about alcohol abuse, about smoking, about sexual preferences, etc. There were only about 16% of the notes where we were not able to identify information that should have or could have been confidential. 65% of those notes were actually written by a single provider. Next slide, please. When we looked at the age distribution for how confidential notes were used, not surprisingly, there was an increase in the percent of notes that were denoted as confidential over time, with the older adolescents in particular having a greater fraction than infants and young children. And we also saw that we were more likely to see a confidential note type used for girls than boys, again, in particular for the older adolescents. Next slide, please. When we looked at the categories of information for which the notes were denoted as confidential, the vast majority of them were around mental health, specifically around the patient's mental health. followed by concerns around substance abuse or reports of substance abuse, around sexual history, or physical violence or abuse. Guardian information was also frequently denoted as a reason for a note to be confidential, in particular around parents' mental health, but also around sexual history and domestic violence. And then we had a good fraction of notes that were denoted confidential as a result of complex social situations. Next slide, please. So 54% of the notes that we reviewed actually included behavioral and mental health concerns. Often this was information that providers documented and documented meetings separately with the patient and the parent. So they often had information that was shared by each one separately and privately. And some of the notes also noted mental health diagnoses from specific family members. About 16% of the notes documented parental mental health diagnoses, and some of those included comments about a parental's ability to manage the patient's medical care as a result of their mental health concerns. These notes were documented by both mental health providers, primary care, and subspecialists. So it was really across across all of our provider types. Next slide, please. Additional confidential information included a lot of information around a patient's sexual reproductive health. So patient telling us about sexual practices, sexually transmitted illnesses or contraceptive use, as well as gender identity and management. And then there was a good amount of information around maternal information. In particular, in our neonatal HIV and hepatitis C clinic, we saw a lot of notes where really most of the information was around the maternal HIV diagnosis and hepatitis C diagnosis, which was not to be shared with the parent, with the other parent, or down the line with the adolescent. There was also some notes around physical or sexual abuse for both patients and parents. Social services involvement was in a fraction of the notes, so where biological parents had lost custody of the patient. And then again, as I noted, complex and challenging social situations, in particular where there was contentious relationships between the parents, were also noted to be confidential. Disagreements related to diagnoses or the plan of care were actually a very small percentage of the notes that we reviewed. Next slide, please. As Dr. DeRoche noted, there are quite a number of exceptions, or really a few exceptions, that are very pertinent to the situations I just noted above. This includes the preventing harm exception. If there is a risk of physical harm to a patient or to another person, in instances around domestic violence or physical abuse, or a true concern around suicidal ideation as the result of information being made available, this would be an exception to be used. Privacy as well, which is the one that we've been using the most, which is really around information that is noted by either the parent or by the adolescent with the expectation that it not be shared with another. And then our state laws. The Cures Act does state that if there are other laws that override anything in the Cures Act, that we can also keep that information separate or confidential. And this is again around situations around minor confidentiality laws. Psychotherapy notes can also be excluded. And then there's also a note around legal proceedings. So if the information may be used in anticipation of administrative or legal actions, that information can also be kept confidential. And this is often used by our child protection team. Next slide, please. So we are now live across all of our locations with all of our notes. All of the notes are live unless they've been designated confidential based on an appropriate exception. And we do have our providers add an audit text to justify the confidential status of those notes. So that's a brief journey for us, and I'll hand it back over.
Thank you. You got to so many components I know people have had questions about, and there's more questions coming in. I'm now going to hand it over to Dr. Kuelbs. Dr. Cynthia Kuelbs is the Chief Medical Information Officer at Rady Children's Hospital and a clinical professor of pediatrics at the University of California, San Diego. She's board certified in pediatrics, child abuse pediatrics, and clinical informatics. Dr. Kuelbs is focused on using health information technology to improve care, engage patients, and better understand what factors influence health and healthcare. Welcome, Dr. Kuelbs.
Thank you. Can everybody hear me?
Yes.
Good. Okay, I'm going to build on what Dr. Bourgeois discussed, and first I'll give you an overview of our journey to OpenNotes. Background on us, and I do give a shout out to all of you who are struggling with the weather. I think it's I don't know, 60 some degrees here in San Diego. So we're the only children's hospital in the San Diego County region, and we serve basically southern Riverside County and San Diego County and Imperial County out to the Arizona border. Our natural borders are the ocean, the Mexican border, and Arizona. We're an integrated delivery network, so we have a shared electronic record that encompasses several primary care groups with about 170 or so primary care providers, virtually all of the specialty care in the region for pediatrics other than Kaiser and the Navy Hospital, and then the acute care hospital. We're all on the same version of Epic. It's Enterprise. Our patient portal is MyChart. And we've been live on MyChart for about almost 10 years. We had a big push to engage patients with MyChart because our telemedicine platform relies on integration of Zoom and MyChart. And so beginning with when the pandemic had the stay-at-home order, we rapidly transitioned to telemedicine, which was really a push to our MyChart activation. And we allow our teens to access their telemedicine visit either through a teen account or through a parent account. As of the end of January, we had about 2/3 of our patients active on the portal. We have about 250,000 MyChart users. And our patients more commonly access the app through the MyChart through the mobile app, but some through the web, and you can see our trend lines there from August to present of the mobile user accounts. Next slide. Thank you. Our journey to OpenNotes began back in 2015. We've been a big fan of the OpenNotes initiative, but took a while to get to where we are today. Our Teen MyChart went live in February of 2016, and we took a different strategy than Boston Children's did. So for our teens, they get their notes, the proxy access to notes is cut off at 12. So from 12 to 17, notes go to the teens. So we don't worry about the confidential or sensitive information getting released to the patient. That has obviously some downsides in that the proxies don't get any notes. We went along in this journey and we're not making a lot of progress. And for those of you who aren't live on OpenNotes, I think from the survey there are a fair number of you. We eventually got our Family Advisory Council to write a letter really talking from a patient perspective what how they would use OpenNotes and to really respect their wish to engage with us and to participate in care. And we had started with an opt-in methodology, and I'll show you the graph on how well that worked, and kind of plugged along and eventually got to the point where we are today, where we have inpatient discharge summaries, all the specialty notes, emergency department and urgent care and primary care. Can you go to the next slide, please? So this shows how we did when we relied on our providers to click a box to share with the patient. And when we went to not requiring them to do that, we went up dramatically, and we're around 90+% of our notes are now being shared, with really very little of the concerns that providers had about sharing notes with the patients coming to fruition. So our current setting is that every clinical note written by a provider is shared by default, unless it's marked sensitive or from a confidential department. We do have confidential departments, which is our child abuse program and our mental health treatment programs. Our adolescent medicine and pediatric oncology are not necessarily sensitive or confidential departments, except for one that is our the reproductive health state-funded clinic through adolescent medicine and pediatric gynecology, and that's so that all of the elements of that encounter are protected. The bills and that don't go to the parent, and so that is a confidential department. So we do have a diminished capacity for proxy that that relies on a grouper of diagnoses to trigger to set that allows those parents proxies to have full access. Once the youth hits 12, notes are released again to the patient, and we do require teen parental consent for teen access. So both the teen and the parent sign that consent. On March 1st, we will be sharing all the notes in the CURES data set unless they're marked sensitive or from a confidential location. Because our strategy was to get the notes to the teens, we wondered, could they understand the notes? Does it provide value? There were people that said, you know, the kids aren't going to understand the notes, so why should we release to them and not to the parent? So a group of investigators here at UCSD and Rady did a small pilot study on a group of patients in a GI clinic, and they provided their teen patient with a recent medical visit note to read, to look at their understanding and their understanding of it, as well as their ability to provide feedback on things that were inaccurate. So we surveyed the patients about their health status, if their medical management change had occurred, and if they wanted to edit the note. They also took a test of functional health literacy in adults to demonstrate whether they were able to understand the medical information. And then 2 physicians read the notes and answered some questions as well about the patient health status and medical management. And then next slide, please. We did find that that the patients were able to understand the note. About 7% requested that their note be amended, usually related to a wrong list of medications or allergies. The youth really liked getting these notes. They were satisfied with their health status documentation and the documentation of visit events. And the teens were in concordance with the physicians on the interpretation of whether a change in management had occurred and overall health, and how the overall health status was described. So I think that this was a nice pilot study to look at health literacy, satisfaction, and comprehension by our youth. And we didn't see any differences, even though in a small study, by age, ethnicity, or gender. Next slide. We also then took this same methodology and went to our inpatient psych unit. Our child and adolescent psych unit is, right now, those notes don't get shared, although we're not sharing any of our inpatient notes, as I said. So we wanted to look at the mental health notes and to see the teen's ability to understand that note as well. Our psychiatrist chose to take a recent progress note, at least one, rather than the history and physical. And these were teens that obviously had significant active behavioral health concerns. And they were able, though, to understand and express their satisfaction with the medical documentation. Similar to the last study, we did look at whether the teens could understand the medical issue, the health literacy, whether they were health literate. And so they had the same test of functional health literacy administered to them. And 19 out of 20 did demonstrate that they were health literate. The psychiatry provider who had authored the note was surveyed at least one day following, and in some cases more, to see whether the note reading had any impact on subsequent inpatient counseling and therapy compliance. And the teens were again able to comprehend their notes. They were satisfied with the content of the note regarding their description of their mental health issues and their reasons for admission and care. There were again some, about a quarter or so, a third, that did suggest edits to their notes, and none cited any confidentiality concerns. Overall, there was either a positive or no effect on inpatient counseling sessions and therapy compliance. Next slide, please. One of the other issues that we have, that I think is a special case in pediatrics and in with adolescents in some cases, is can some child abuse consult notes be shared, and what protections should be considered if abuse is an issue. So I'm going to talk first about our child abuse reporting practice, and then I'll talk about the specific case of medical child abuse, which raises some issues about note sharing and confidentiality. So when we went live with our inpatient EPIC electronic record back in 2011, we created an electronic process that allowed us to do our state reporting for child abuse within our electronic record. We wanted it to be easy and accessible for mandated reporters, provide access for case review, generate data for analysis, work for everybody in all environments, and then protect our records from being inappropriately released. Next slide. Thank you. So we have a child abuse report that's a specific note type, and this process gets automated based on that note type. So if the child abuse report is filed, then the flag is set that restricts portal functionality. It doesn't allow any past visit information, but people accessing the portal can still see upcoming appointments, labs, imaging, and they can also message the care team. One of our issues with this system that we have is that we don't have an end date to this restriction, and so we're working to define that, to rescind that, and to also we'll incorporate that process into our existing audit process to look whether the the proxy should get full access again. And we also are looking as to whether the offending parent or legal guardian's access to the portal should be deactivated. So in some cases, as you know, many cases where a child abuse report is filed, the parent or the proxy caregiver wasn't the person responsible for that abuse, so we don't want to prevent them from being able to access full functionality of the portal. The child protection team consult notes are defaulted to sensitive and aren't shared. And a question I think here that we need to address as child protection physicians, child abuse pediatricians, is whether some of our consult notes can be shared. About half of our consults that we get on the inpatient side may not result in a diagnosis of abuse or a feeling that is abuse, and certainly the parents or the proxies are not always the abuser. In those cases, the child abuse pediatrician is getting a history from that family and documenting their concerns. And in my practice, I tell the parents or the proxy of caregivers exactly what I'm, for the most part, going to put into my note. So I think this is something that is, I'm hoping we can discuss and perhaps change our practice in that way. And one of the examples of this is a parent whose child may have sustained a femur fracture as a baby in daycare. The parents weren't there, and we wouldn't allow them to see the child protection team note, and yet they weren't involved in that abuse. And reading the note could provide some value to them. So I would like to see this issue looked at. Next slide, please. Medical child abuse was formerly known as Munchausen syndrome by proxy. It's a term used to describe unnecessary and harmful or potentially harmful medical care that occurs at the instigation of a caregiver, where they exaggerate, fabricate, induce symptoms, and this can result in unnecessary and even dangerous medical procedures. Basically, the medical system gets manipulated and taking part in really abuse of a child, either psychological or physical. These are very complex cases. I think anybody that works in pediatric healthcare, certainly in Children's Hospital, is well familiar with these. And it's very difficult for providers who have concerns about medical child abuse because they may be reluctant to document those concerns. They could feel pressured to engage in the interventions being requested by the parents, and they're worried that if their notes document concerns, they'll be released to the parent and result in harm to the patient or a damaged physician relationship. So we have a multidisciplinary team that does review these cases and support medical decision-making by treating providers so that we can empower them and help them to provide standard care and reduce or prevent ongoing medical child abuse. I'll talk about the note restrictions on this to date, but remember, in this situation, while the child protection team note would be automatically flagged as sensitive, many of the other notes that could contain information about this would not be marked sensitive and would require a provider to really think about whether that note should be released or not. We have, to date, educated clinicians on the warning signs of medical child abuse. We have a registry to track these patients, some system alerts, and then follow up with outside physicians and institutions to further the ongoing care. Can you go to the next slide, please? Our tools are that we have a problem list entry created, calls risk of harm due to overutilization of healthcare, which is a sensitive diagnosis, and we have the registry, as I said, an emergency care plan, and then a form that captures the referrals and concerns, and that can help with that goes to the registry, and then some in basket, which is the EPIC term for the in electronic record communication to alert specialists that are providing care for these patients. Next slide, please. This is the registry. So one of the things to consider here is that not all patients where medical child abuse is suspected have had a child abuse report filed. That decision to make the report can take some time, and there can be lots of concerns raised and discussions ongoing. But this illustrates some of the fields that we pull into this registry, and you can see it with the purple arrow that not all of the patients, in fact, it looks like roughly half, have a child abuse report filed. And so then all the actions that we trigger off of that aren't going to occur in these cases. Next slide, please. This is the smart form that has some of the narrative that goes in. So this is then again used to track who's doing what on this. These fields file into the registry, and it's a nice way to track what's going on with these patients. Next slide, please. This is a message that we put into the in-basket that can alert other specialists. Next slide, please. And this, can you click again, please? This is the emergency care plan that goes into the record. And so there's a banner that files so that people that are providing care, providers providing care for the patient can see that there is a concern for medical child abuse. And so to think about very carefully about doing any type of procedure that could be painful or harmful, and to contact the on-call child abuse pediatrician for more discussion. Next. So again, our release restrictions are for those patients with the child abuse report filed. Given that this problem list entry is sensitive, we are going to trigger restriction based on that problem list entry. And again, our child abuse notes are marked as sensitive, but other notes could contain information that details concerns for medical child abuse. And as we move forward with our note release for 21st Century Cures and expanding that, we believe that any note that details medical child abuse can meet the preventing harm standard, or certainly with 21st Century Cures. And so it's just making sure that our providers are alerted to this and thinking about it so that they do mark those notes as sensitive and not share. And we're hoping that our current tools and all the alerts that we have that there is this consideration will prompt our clinicians to do that. Next slide, please. We do allow some of our foster parents access to MyChart, both for teens and younger children, but it has to be at the designation of a county social worker, and these are long-term foster parents. We've been doing this for several years, and this has been really beneficial for the care of these children for all the reasons that Dr. Bourgeois outlined as the patient portal benefiting. Next slide, please. Patients with eating disorder, I think these are some of the questions for consideration that we have had around patients with eating disorders. We have had discussions about where there were requests to block access for these patients for a defined period of time, about not sharing the notes, it being therapeutic or harmful, whether the note should be shared. And again, the question is about whether it's therapeutic or harmful. I think 21st Century Cures regulation is really clear that the decision to not share information with a patient needs to be individualized. And so this cannot be applied blanketly to a patient population having a specific diagnosis, and needs to be applied at the individual patient level based on the questions of whether it would be harmful to share the information with the patient. Next slide, please. That just specifies, that's just the language. And that's it. Thank you.
Fantastic, thank you. And I love how this presentation arc is the basics of OpenNotes and what was done at Boston Children's and then at Rady Children's. And you, Dr. Kuelbs, really got into the nitty gritty of many of the questions we've been receiving up until today and even in the chat box right now. So due to time, 9 minutes left, I want to respect everybody's time. We're going to skip the mini panel and kind of get into the broader Q&A, but also Dr. Kuelbs, Dr. Bourgeois, I encourage you guys to continue to ask each other questions during the main Q&A. As we jump in, I just want to remind folks that we do have more events coming up, more presentation opportunities for you to plug into in the next few weeks. You're all on our mailing list now, so you'll be notified about those, but we're doing a webinar on OpenNotes in oncology, open inpatient notes, and then we're going to have a special OpenNotes walk-in clinic the week leading up to April 5th and the implementation of the Cures rule. All right, so we're going to Q&A, and Deb, you'll hear her voice as she starts to ask our group some questions.
So a question that's come up in a couple of different ways is around parents being able to access their teen's account. And they wanted to hear your thoughts if you've run into any issues around this.
Is that for me or Dr. Bourgeois? I can tell you our experience.
Both.
Either one. Well, I'll speak from our perspective. So because our parents don't have access to the notes, if they have their teens log in, they can use that login to read the notes and communicate. And we are looking at a QI project to see how often that is happening. So we looked at about 4,000 messages of the between a teen account and a provider. And it was pretty clear when the parent was using the account, because they weren't shy about saying, "Hi, I'm Johnny's mom," or "Thank you, Mrs. Smith," or what have you. There were no confidential messages that we saw that were breached that the parent got involved in on that. But I think the concern that we have is we can set it up the way we have it set up to provide the protection needed for the teen in saying this is going to a teen email address, the teen consents, the parent consents, everybody agrees, here's what the settings are. Once it gets to the teen and the family, they can choose to do what they want with that, so the teen can provide the login information to the parent. We did talk about having a non-coercive consent process so that the parent would have full access, but we didn't pursue that path for a variety of reasons. And our path is very different than Boston Children's in that we're sharing all the information with the teen, the parent's getting nothing, and that's to protect a small amount of sensitive information from getting to the parent while disadvantaging parents who have kids with chronic illness. So for us, this isn't the perfect solution, and one that we're looking for a better way to approach while still protecting the teen information and allowing the teen to have the information on their reproductive health issues, which is the biggest one for us.
So yes, as Dr. mentioned, our strategy is slightly different in that we continue to allow access to parents of adolescent accounts because we really filter out confidential information. There is always a risk of inadvertent disclosure, certainly among the adolescent. And you know, as Dr. Kuelbs mentioned, it's a risk-benefit discussion ultimately in terms of you know, access to all the non-confidential information versus not, and the technical ability to really be able to filter out confidential information. I will say it takes a lot of time. It's not a light technical lift in terms of really making sure that all the confidential information is continuously filtered out of the portal. What we have seen actually is a shift from parents trying to get access to their adolescent accounts to parents trying to get access to their 18-plus-year-old accounts. So we've just essentially, it's just been a shift by a few years in terms of where we're seeing the same problem and are doing similar techniques where we're auditing our adult accounts to try and make sure that the parents are not the ones who are accessing those accounts.
Either one of you could answer this. If a teenager is in foster care, are foster parent caregivers treated as proxy, or does that have to be approved separately?
For us, it's a separate process for the caregiver. So we have our legal team that gets involved, and we have, similar to what Dr. Kuelbs had previously described, we also have required DCF to send us a document stating that the foster parent can have access to the portal.
Ours would be the same process. We have to get our CPS approval for that foster parent to get access to the portal, but once they did, they would be treated like any other caregiver proxy. They still wouldn't get the teen notes. The sensitive labs don't go to anybody right now. That is something that we may do differently than Boston. And well, actually we do the same as Boston, because you don't release the sensitive information, the sensitive labs, and then the teen would still get their notes.
Okay. A question for Dr. Kuelbs. How does Rady address documentation of psychosocial information created by the social work department?
Yeah, I love this question. So right now our social work notes are going to be automatically marked sensitive. And that's because we need, they do contain some sensitive information. I would like to change that, because I think, again, many of them don't have sensitive information, but with the March 1st, our decision to get all the notes live March 1st, we're going to start with them as defaulting to sensitive, so they will not be released. And it, you know, it bothers me. I'd be curious to see what you're doing with that, Dr. Bourgeois, because that information is really helpful to families in many cases, that they've spent a lot of time talking to them and provided them with guidance, and then they're not going to get the note. So I would love to hear your experience as well.
Yeah, I think you're exactly right. And that's the same discussion we had with our legal team and our social work department. And so our social work notes are handled just as the same way that we handle any other note, where it's on a case-by-case basis, where they select whether or not the note is sensitive or not.
Our confidential, sorry.
Go ahead, Deb. This will be the last question we take right now.
Okay. Are confidential note types released upon a release of information request by a parent? Same question if ROI submitted by physician's office or insurer.
Yeah, so it is, so right, exactly. If it's confidential status that doesn't go to the portal, does not mean that it's confidential from an HIM release perspective. They have different rules, different filters in terms of how information is released. So it can still be released depending on the reason for which it was marked confidential. It may still be released to a parent based on their specific review. And we have slightly different rules in terms of how, and it's actually a whole different discussion in terms of how we manage health information exchanges and releases to our kind of our provider portals, because there are different rules from the patient portal to the provider portal.
I will jump in.
The same, yeah. Oh, sorry.
Go ahead, Dr. Kuelbs.
Relative to release of information, just because it's marked confidential or sensitive doesn't mean it won't get released through the ROI process.
Thank you. I'm only breaking in to say, you know, some folks need to go at the top of the hour, and I want to thank everyone who showed up today, and especially thank our two presenters who gave us so much excellent information. Both Dr. Kuelbs and Dr. Bourgeois will be with us again next Tuesday at the same time for a full open office hours Q&A session where we can continue to get more into these questions. Sadly, there are 50 questions and we couldn't get to all of you guys, and we would love to. So we invite you all, and we'll share the link in the chat box where you can sign up for open office hours next Tuesday. I think that's it for the day. I did want to remind everyone, because you're here on this webinar, you will get an email in about a week with a recording of the session, link to a PDF of all of the slides, so all of those great screenshots with lots of text. You will be able to access that information in about a week. And I think that's it, even though I would love to go more into the Q&A. Dr. Kuelbs, Dr. Bourgeois, you guys were excellent. I really appreciate you guys being here and sharing this information. And one last shout out to anyone who attended today. You're probably the most knowledgeable person at your organization about OpenNotes right now. So take what you've learned, watch the presentation again, and share it with everybody you know when they have questions. So thank you so much. And thank you guys one more time. Have a great day.
Thank you.
Yeah.